Hi, I'm Jay Ostrowski, and I'm a consultative partner with the Mid-Atlantic Telehealth Resource Center. And I'm here with Bonnie Britton. She's a nurse, and she's also a co-founder and CEO of Reconnect for Health. And Bonnie, would you tell us a little bit about what Reconnect does? And then let's talk about chronic care management and remote patient monitoring in a little more detail.
Well, as Jay said, I am a nurse. I'm a master's prepared nurse, and as of May of this year, I've been in the remote patient monitoring space for 20 years. Primary focus is on the clinical end of remote patient monitoring. 2 years ago, we started my own company, Reconnect for Health, and we are a nurse-owned company, and we provide remote patient monitoring consultative services for potential customers to help them understand their return on investment, how to develop their clinical workflows, how to really set up a program that's going to be successful and scalable, that's going to demonstrate a return on investment. As well, we have registered nurses who can provide the remote patient monitoring services for customers who either lack the registered nurses internally, they don't have the infrastructure to be able to support implementing a program and scaling it. And we are not a traditional call center. We like to call ourselves a connected care center, because our focus is on the patient and providing extensive health assessment of that patient, as well as med reconciliation and escalating useful actionable data to the patient's primary care provider to prevent exacerbation of disease and keep people at home and age at home.
Yeah, and so one of the reasons we're talking today is because you're an ATA fellow. You've been doing this for a really long time, and not many people have your level of experience. I'd say just about nobody has your level of experience with doing chronic care management and remote patient monitoring. There are a lot of little kind of technical parts to that that we want to talk about as we go along here. But just to kind of start at the high level, why should we do this? Why should a hospital or a clinic start doing remote patient monitoring or chronic care management?
Okay. For me, that's an easy sell, and I'll give you many reasons for that. Number one is we have a healthcare system that is designed for payment to benefit healthcare providers for bringing patients into a hospital or into a clinic. And as patients age, there are not a lot of services other than home health services that are available for people to stay in their home. So with remote patient monitoring, by placing a scale in a heart failure patient's home, being able to get up every day and see what their weight is to better start understanding their medications, to understand what an increase in weight will mean, knowing what they need to do when they're feeling certain symptoms, it empowers that patient. It empowers them to become engaged in their own care, to understand earlier when they're having an exacerbation of the disease. The other thing that it does is it creates long-term behavior change. And there are remote patient monitoring programs that implement the program purely from a financial perspective, and that's okay if that's what that organization needs to achieve. But what we have found over time is it takes approximately 78 days to create long-term behavior change. And so for a lot of the remote patient monitoring programs that begin with 30 days, they end up monitoring those patients for longer periods of time, because the ultimate goal is to help the patient become more engaged and create behavior change.
So when you're talking about behavior change, so stepping on a scale, that's one of like many different things that you guys do, put in a home. So that scale raises awareness. Is that right? But then there's like some interaction with a nurse that has some accountability elements. Is that right?
Absolutely. So the process for remote patient monitoring is delivering the devices to a patient's home or giving the devices to a patient's home, depending on their diagnosis. The peripherals that are mainly used in remote patient monitoring, this is not all exclusive, but the majority of the programs are a weight scale, a blood pressure pulse monitor, finger stick blood sugar, and a pulse oximeter that Jay has on his finger. And collecting data for data's sake it does not create behavior change. So earlier when I said that we're not a traditional call center, we're more of a connected call center. Let me tell you what I mean by that. Traditionally in a call center, what occurs is if there's an alert, if that patient's vital sign or biometric data is too high or too low, a center calls that patient and they validate that that alert is indeed theirs, and they may instruct that patient to retake their way, but nothing else occurs. And so we take it further than that. We call the patient, we validate that alert is theirs. We also validate that they rested the proper amount of time or followed our instructions on taking those readings. If they did not do those things, we re-educate them, re-instruct them to take another reading. Before instructing them, we do a health assessment on that patient. Are you more short of breath? Are you short of breath at rest, on activity? Are your ankles swollen? Are you having headaches, etc.? And then based on that nursing assessment, we utilize what we call see, feel, change methodology. Patients can see their readings. The nurse helps the patient articulate how they feel. And that is what creates behavior change, because they make that correlation between what they did or did not do yesterday and how they feel today.
Okay, so it's kind of a series of things that go together that create this this cycle. So they become aware, but they're also kind of interacting and being educated along the way. And it sounds like sometimes with the devices there are false positives that can trigger maybe undue costs, whereas your nurses can call and say, hey, when you took that reading, what were you doing to make sure it was a good reading? Okay.
Exactly. And for an example, I use this example a lot. I lost my mom 2 years ago at almost 93 years old. And she had heart failure, and we had her on a remote patient monitoring program for many years and kept her out of the hospital for 6 years. Wow. As a nurse, if I told my mom once, I told her 1,000 times, I know you love Chinese, but you can't eat it. And I would tell her why. But she would continue to eat it. Until a nurse called, her remote monitoring nurse, and said, Mrs. Perry, your weight's up today. Is your abdomen distended? Because that was always her first sign of heart failure. Yes, it is. Are your feet swollen? Yes, they are. Are you more short of breath? Yes, I am. What did you eat? Did you take your medications? Yes, I did. What did you eat yesterday? My husband took me for Chinese. Okay, Ms. Perry, let's talk about why you feel the way you do today. And if you want to avoid feeling this way again, then you will avoid Chinese food. Okay. That worked because she made that direct correlation between what she did and how she felt.
Now, if what would happen, just hypothetically, if her symptoms got worse and the nurse is with her on the phone, or not on the phone, but just if their symptoms got worse and the readings got worse, what's the next step there?
The next step is contact that patient, and if we, based on the nursing assessment, believe it's an emergent situation, then we'll instruct that patient to call 911. If there's someone on the family there to be able to call 911, we stay on the phone with that patient. If their patient's there by themselves, we get off with the phone with them, and then they call 911, and then we call and stay on the phone with them until ambulance gets there or EMS gets there. Okay. For patients who are symptomatic, but based on the nursing assessment, it's not an emergent need, then we escalate that data and information directly to the patient's primary care provider. Okay. Who then can say, we need this patient to come in, or this patient needs a medication adjustment, etc. That's the ultimate goal, is to take that actionable data that's useful, send it to a primary care provider who can then add the medical intervention on top of it, and that's what really closes the loop and helps prevent patients coming in.
Yeah, so it's proactive approach to
Correct.
Monitoring and engaging them and helping them at the point when they're open to learn, when they're in pain from swollen ankles or abdomen. Okay.
Exactly, because Our patients, when they're discharged, no matter what hospital, if they're the best in the world at discharge planning and patient education, those last 2 days in a hospital, especially the last day, you recall so little of what has been told to you.
You just want to go home.
All you want to do is let me go home. And then you go home and you feel better. And then you go to get those medications that are not generic, by the way, and the patient can't afford. So this is another way did you get your new medications? You didn't. Why not?
So this is part of it could be a readmit reduction strategy too. Obviously, we all need to decrease readmits. So that could be you mentioned something interesting, and I want to talk about financials in just a minute, but you said some companies do this for financial reasons, and that's okay. Part of me thought you meant it's okay because everybody has their own reasons, but the other part of me thought it's okay because it's still a good positive outcome for the patient.
Correct.
Even if they're not doing it 100% correctly by having nurse intervene, some monitoring is better than no monitoring. Is that accurate?
That is very accurate. And the largest program I ran was at Vidant Health in Eastern North Carolina. So, for an example, at Vidant Health, they implemented a post-discharge remote monitoring program for Medicare patients to decrease less than 30-day hospital readmissions. And we started that program monitoring those patients for 30 days. We had very good outcomes from that. But at the end of the first quarter, what the finance department realized in conjunction with the clinical data that we were able to provide is that these patients were staying out of the hospital. They were becoming more engaged. Their patient activation measurement scores that we were tracking on these patients were improving. And so they saw that even though they looked at this project first as just a 30-day financial project, it turned into then a 90-day monitoring period for these patients with the goal of decreasing ED visits, decreasing overall healthcare costs for that patient population. Wow. So really dependent upon, if you're a primary care practice, especially a federally qualified health center, you utilize remote patient monitoring for other reasons. That is, patients have health illiteracy issues. They have transportation issues. Yeah. They have issues with the finances to be able to pay for that copay. So really identifying the vulnerable patient populations, no matter what setting you're in, you're going to have positive outcomes from that.
Now, I don't know if we're allowed to mention the name of the company that you did this with, but you worked with a fairly large health system that did a study of indigent patients and monitoring and looking at, because that's just 100% cost.
Exactly.
And as much as we hate it, we have to talk about costs, and because it's part of the reality we live with. But you did a study, and I was very surprised about the outcomes. Can you mention any part of that?
Absolutely. When I was at Roanoke Chowan Community Health Center, which is a federally qualified health center, we implemented the first patient-provider telehealth network in the country. And what I mean by that is we actually had the primary care providers at our clinic, our center, as well as 7 other community health centers across the state of North Carolina. They were identifying patients with cardiovascular disease, pulmonary disease, and diabetes, and really looking at those patients who are the most vulnerable. So transportation issues, financial issues, non-compliancy issues, or I should say non-adherence, because I really don't like the term non-compliant. So those patients that no matter what they did, they couldn't get a handle on what was going on with those patients. So through that study, we had one central center for the registered nurses that were doing the monitoring for all of the patients across the state. And we hired Wake Forest University to analyze our data, and we demonstrate statistically significant reduction in overall healthcare costs, and we decreased hospitalizations by 76% and decreased overall healthcare costs by 76%.
That's impressive.
It was extremely impressive, and the outcomes. Some of these patients we monitored for years because the living situations were so poor. Let me give you an example. So Wake Forest Baptist Medical Center, I've already said that. The results of that study were published, and Jay, I'll be more than happy to get the reference to you so that you can add it to this video.
Sure, that'd be great. So so remote patient monitoring is seen often as a cost because there's no reimbursement directly for that. But you've talked to me at some points about people actually funding their remote patient monitoring service with chronic care management that is reimbursed.
Absolutely.
That's one of your specialties. So can you tell me more about chronic care management?
Sure. Medicare implemented a chronic care management, CPT code 99490, January 2 years ago. So that was January 2015. The purpose of the CPT code was to allow primary care providers, internal medicine physicians who provide care to Medicare patients with 2 or more chronic conditions to be able to provide 20 minutes of non-face-to-face care coordination. And so for the first year, there was a very slow uptake in CMS's chronic care management and implementing those programs. And the primary reasons for that are the following. Number one, patients had to come into the clinic for one of 3 types of visit codes. And that was a barrier because if a patient came in for one of these evaluation codes, it takes longer for the physician to provide that service. Therefore, the physician can't see as many patients that day and meet their numbers that they're supposed to on a daily basis. So that was one barrier. Another barrier was where physicians did not truly realize the amount of revenue that could be generated as a result of implementing CCM, and I'll discuss that a little bit further. The other barrier was most electronic health records do not have a patient-centered care plan, which is a requirement of CPT code 99490. Most EHRs have a patient or a physician problem list, but not a patient plan of care. The other barrier was that you had to be able to electronically time the amount of time you were spending with that client so that you knew exactly what was done for those 20 minutes, when it occurred, and that it was time-stamped so that you could then submit to Medicare for billing.
So I could see as a manager that would be kind of a logistic nightmare to keep track of. And what if you have more than one person doing the care, because sometimes it's a team. So was that a challenge also?
It absolutely, without an electronic timer, I really don't know how people are being able to manually track that. So the important thing here with chronic care management is the criteria actually in January of this year loosened, and 2 additional codes were added. And so let me talk a little bit about that. Any Medicare patient that has 2 or more chronic conditions qualify for chronic care management. And chronic care management can be billed by an MD, a mid-level, whether it's a nurse practitioner or a physician's assistant, as well as clinical nurse specialist.
So wait a minute. You said 2 or more chronic care issues.
Chronic conditions.
That's like most of the patients, right?
Absolutely. Okay. That is correct.
It's kind of hard to get my head around that from it. Really, the majority of the patients would qualify.
That is correct.
Okay.
That is correct.
And that's actually the intent of Medicare?
It is.
Okay.
That is the intent, is to provide coordination for these patients.
Okay.
Now, who can provide these services? The services are not provided directly by the physician or the mid-level or the clinical nurse specialist. The services can either be provided by an RN, an LPN, a nurse assistant, or a medical tech, whether they're within that practice or actually it can be outsourced to other companies who provide those services.
And
Now,
is that billed by the provider's license?
it's billed by the provider's license. That's
Even though
correct.
it's done by a nurse. Okay.
Correct. So when a patient is identified, which are the majority of the patients, as you stated, Jay, then they now can verbally consent while they're in an office visit, or they can verbally consent over the phone.
Okay.
Once that patient has been agreed to participate, then a non-clinical person or an LPN contacts that patient via phone, completes a health assessment, then takes the data from that health assessment to a registered nurse, who then needs to develop the plan of care. So data collection can be obtained by someone other than a registered nurse, but the development of that care plan and the evaluation of that care plan, it has to be done by at least a registered nurse.
Now, something that surprised me when we were working on this toolkit for remote patient monitoring and chronic care management, something that surprised me was that this actually does not require a physician's order, a provider's order.
It does not. It does not.
It's more of a logistical internal management issue, but that's kind of a just kind of a new thing that it can be just done systemically.
Absolutely.
Okay.
So let me give you a best case scenario. So let me give you an example of how an organization or healthcare system can utilize the combination of remote patient monitoring and chronic care management to increase revenue opportunities.
Okay.
So if you implement a program from your hospital where you identify Medicare patients with 2 or more chronic conditions, and for patients who are eligible for remote patient monitoring, refer those patients that meet that criteria, and refer them to remote patient monitoring, and then schedule an evaluation and management or an annual wellness visit within 7 days of discharge. The provider who provides that service within 7 days of discharge, their reimbursement is almost 3 times the amount if you wait till day 15.
Hold on. So when you started with your reimbursement, the video got slow.
Oh, okay.
And then, so when you discharge patients, the provider that provides?
Yes. So when patients are discharged and they qualify for remote patient monitoring, you can refer them to remote patient monitoring at discharge. In addition, you will want to schedule an evaluation management or annual wellness visit with the patient's primary care provider within 7 days of discharge.
Okay.
If you do that and that patient is seen within 7 days, then that provider's Medicare reimbursement is 3 times greater. So take advantage of that. Bring that patient in within the first 7 days. So for the patients who don't qualify for remote patient monitoring that have Medicare and 2 or more chronic conditions, they also can be scheduled within those 7 days. And when they come to the clinic, they would be enrolled into chronic care management.
Okay.
So the opportunity is, you've got the whole population of Medicare patients with 2 or more chronic conditions. Some of them will qualify for remote patient monitoring based on the or goals of the organization or the healthcare system. Others will be discharged with a referral to chronic care management. Both groups need to have a visit in the patient's primary care clinic within less than 7 days for additional reimbursement. Okay. During that visit, they're enrolled into chronic care management. Then, as soon as the health assessment is completed and the patient care plan is completed, and if you have met, and you will have met from experience, 20 minutes and during that first phone call, then that provider can bill Medicare. In January of this year, Medicare released 2 additional CPT codes for chronic care management. So initially there was CPT code 99490 for 20 minutes of non-face-to-face care coordination, and that reimbursement nationally, the average is $42.60, plus a 20% copay, which we'll discuss in a few minutes. In addition to that, there's CPT code 99487. So if you have a patient and they receive 60 minutes of chronic care management services in a month, then you can bill an additional, or you can bill for $107.
Okay. So is that in addition to that?
No,
Okay.
no, it's either 4260 for 20 minutes to 59 minutes.
So this year they basically recognize that some of these chronic care patients need a lot more chronic care.
Exactly.
So they're incentivizing that level of care.
Exactly. And for your patients who are remote patient monitoring and chronic care management, reaching 60 minutes in a month is an easy thing to do.
Okay.
Much easier
and
than just chronic care management.
What leads to that 60 minutes?
Because each day the patient's taking their readings, the nurse is reviewing those readings. If there's anything abnormal, they get on the phone, they start talking to that patient, and all of that time is electronically captured. When they finish the call, if they need to call the pharmacy on behalf of the patient, if they need to call the provider on behalf of the patient, if they need to coordinate transportation, medications, etc., that is all being done on the behalf of that patient and can be counted into that payment. In addition, they have included a CP code 99489, and that's for patients who have met the 60 minutes for $107, and you reach 30 more minutes, then that reimbursement's $53. So those can be added together.
Okay. So you were mentioning something about copay. You said we'd come back to that.
Yes. So in the Medicare language from when Medicare originated, there's always been a 20% copay for patients.
Okay.
That applies to chronic care management as well.
Okay.
That's a huge barrier for a lot of Medicare patients. CMS is aware of that. Last year in 2016, they had conversations that they know they need to redo that, but they can't just recall that.
And technically speaking, the provider needs to attempt to collect that.
That is correct.
Okay. They may not be successful, but they are required to attempt to collect that. Okay.
Sorry. Yes, that is correct. And so here's what I recommend our customers or anyone I'm speaking with is identify the number of patients that are Medicare with secondary insurance and start there. For an example, one of the organizations I've been working with, Appalachian Regional Health in Appalachia, Kentucky, they ran a report of all of their Medicare patients with 2 or more chronic conditions and that had a secondary insurance. And there were a little over 4,000 patients that met that criteria.
Okay.
So they initially, and they still are in the process of enrolling all 4,000 of those patients into chronic care management, because then in addition to billing Medicare, they can bill the coinsurance and receive that payment.
Okay.
That way, if you have time to build your program, you have time to create stories. It creates time to be able to explain to patients the benefit of this, to pay that $8 copay a month. And that's the real problem. It's a copay every single month you're on chronic care management.
So let's just say that you didn't collect the copay. Is this profitable, or can this be profitable at the rate of not collecting the copay?
Absolutely. So let me find my slide. So let's talk about a return on investment for chronic care management. On a national average, one primary care provider averages a panel of 2,500 patients. Let's just say on the extremely conservative side, and I think you'll agree that this is conservative, that 16% of those 2,500 patients are Medicare. And then let's just say that only 69% of those 16% have 2 or more chronic conditions. I think you'd agree that's a low number.
So you're talking like under 70% of 16%.
Correct.
All right.
So that's about approximately 200 chronic care manager patients per provider.
Okay.
On an annual basis without copay, that provider will be bringing in $102,240 additional dollars into the practice for not providing any additional service by that provider.
Wait a minute. You're saying that just sounds like a commercial, but this is the federal government is funding. If you have 200 patients that have 2 or more chronic conditions that are on Medicare, and you enroll them into chronic care management,
correct,
the provider could get roughly $100,000 a year without doing anything but enrolling the patient.
That is correct. So let me just give you an example. So for Appalachian Regional Health, who I mentioned earlier, they, as I said, had a little over 4,000 Medicare patients with secondary insurance. They started their program with the goal of targeting 1,020 patients, which is less than 25% of their whole Medicare patient population with secondary insurance. Their gross first year annual revenue, because you have to ramp the program up, is right at $227,000. Year 2, which they're in now, once they scale to 1,020 patients, their additional revenue every year is over $700,000.
Okay, so what are the costs of like creating this? Does this take a lot of infrastructure, or what does it take to do this?
Well, primarily, number one is having a software package system that can have a health assessment, that can have a patient-centered care plan, that can be have goals and be able to evaluate the progress of that patient. You have to have a consent form, which is an easy thing to create and provide.
But there's some, I would imagine, like, first of all, people got to get their head around this inside.
Sorry.
So people have to get their head around this inside the organization. And so there's some planning, some logistics,
Absolutely.
Some mentorship to make sure you're doing it well, that you're actually connecting all the dots so that you're doing all the compliance measures to make sure you actually do get reimbursed, that you have an audit trail to be able to prove that you've done everything correctly.
Absolutely.
Is that part of the startup package, or
it is part of the startup package, because just having the devices and remote patient monitoring, you still have to have a clear understanding of the workflow within that clinic. And if you decrease the number of patients a provider seeing on a daily basis, the program's not going to be successful.
Okay.
So it's with Appalachian Regional Health.
What would cause that decrease?
Because the visits may be longer, and the providers would have to spend more time with each patient. So what I would recommend is putting a process in place where you have key staff who work with those providers who know these patients, who on a daily basis can look at that physician's schedule and identify patients with 2 or more chronic conditions, that can then look back to see if patients had an annual wellness or an evaluation management visit in the last year. If they have, then that person can explain the program when the patient comes into the clinic.
Okay.
Then you have to send that referral to someone, and then internally within that practice, they would need to have someone that could conduct the health assessment, then get that information to a registered nurse to be able to create that care plan. And then once the 20 minutes of calls, and that can be provided by someone other than an RN, just to collect data. If it requires an assessment or initiating education, then that has to be completed by an RN.
Okay. So the initial startup, there's probably some planning processes there. You've got to get a lot of buy-in, I would think, and then there are some operational workflow processes and policies, procedures that need to be in place.
Absolutely.
Okay.
And
so someone needs to be dedicated to this project. It can't be just added on top of something else.
that is correct.
Okay.
So out of that additional revenue that you're going to generate, you either need to dedicate part of that revenue for internal staffing,
Okay.
or outsource those 20 minutes of non-face-to-face time to organizations that do that, such as ours. And then there is a split in that revenue.
Okay.
So there's a lot of ways to do this, sharing revenue, doing it internally, but understanding the clinical workflows and getting the physician buy-in is absolutely essential. And
so I want to ask you right there, what are some of the biggest mistakes? I think you're kind of alluding to one of them. Companies that you've watched, you've consulted with lots of these, and startups, and some have worked well and some have not worked so well. What do you see as kind of the biggest mistakes and the challenges of companies starting out this kind of service?
Well, I think I know for remote patient monitoring, I'll speak to that first. Historically, over the last 20 years, organizations who are or entities that are implementing remote patient monitoring spend 95 to 99% of their time completing due diligence on the equipment vendor. Today, early on in our history, that was critical to do. Today, if you go to the American Telemedicine Association, if you go to the National HIMSS Conference, everybody has a gadget. Everybody has devices.
That's
and
right.
Everybody can connect those devices via some transmission mechanism.
Mm-hmm.
And so focusing on the bells and the whistles of the technology really you don't need to spend as much time doing that, because now all these products are FDA approved products.
Sure.
Which you really
most of them, yeah.
Not all, but you want to make sure they're FDA cleared.
Okay.
But then it's really looking at not only the device, but what is their back end? Is it robust enough, number one, for your nurses to be efficient in providing remote patient monitoring services? Are there ways to track a patient's status? Are there ways to create a care plan? Is there interface with multiple vendors? Because now there's so many gadgets out there. Organizations no longer want to just work with one company. They want to be able to look at the devices they need for their patient population and be able to work within a software platform that will allow them to work with any vendor that they choose in a single sign-on process.
Okay.
So the other thing is who's going to be your partner? Who's going to be there? So if there are issues that they're going to be resolved immediately, which partners are willing to adjust their software so that you can get the reports you need from a return on investment perspective.
So it's possible for a company to do it themselves and maybe hire a consultant like yourself, mm-hmm. or someone to come in and start up, but then continue it on their own.
Correct.
Pick their vendor or multiple vendors to use, and kind of cherry pick some of the best. But then there's some workflow issues that they would still need to work out and might need some help with. Okay.
Absolutely, because not only the clinical workflows, but to have an internal champion is critical. Because you've got to have someone with boots on the ground that are going to get the physicians bought into this, a nurse, champion who's going to get these discharge planners and case managers identifying patients and getting people excited about this. And then in return is collecting data frequently, collecting not only the clinical data, but the financial data to be able to go back to those champions who can then take that data back to their colleagues to help further solidify that this program is meeting its goals and objectives, and to sustain and scale programs.
So kind of a feedback loop. So that's one of the mistakes people have made, is not creating the feedback loop where they implement the program, they get the results, and then they give those results back to the C-suite to say, we did meet our objectives, here's the ROI, here's why we should keep going, to kind of continue to build a case for it. Is that correct?
Absolutely. And if you don't do that, you're not going to sustain your program. I've seen program after program after program that did really good work, but they did not calculate and validate the financial return on investment. And without that, the
Now,
program's not going to grow.
so, something that you and I have joked about in the past is we tell people, because you're a consultative partner also for the telehealth resource centers in our Mid-Atlantic Telehealth Resource Center. We joke about telling people don't try telehealth. And the reason we tell them don't try telehealth is it doesn't need to be tried. It needs to be implemented because it's been proven to be effective and proven to be cost effective and really work. It's just a matter of implementing it in your local setting.
Absolutely.
So are there ways to implement this that would not be cost effective? I mean, it doesn't run itself. So are there ways that people do this that poorly, not just the feedback loop, but implement it poorly where it would not make an ROI?
Oh, absolutely. If you do not work with, and we haven't mentioned this yet, but one of the most important things to do within an organization is to work with your chief financial officer, or at least someone high up in the financial department, to help them and the organization understand exactly where you're losing money. It's essential that you work someone with either the chief financial officer or someone in the financial office to help the finance department as well as the organization understand the patient populations that the organization's losing money on. Okay. And that varies hospital to hospital.
Depends on their business model and their operations.
Absolutely. So for an example, with Hazard Appalachian Regional Health Hospital, we looked, their biggest losses were in Medicare less than 30-day hospital readmissions. Okay. So they focused their program and their outcomes from a financial perspective based on that. Now, for another large entity we were working with, they thought that Medicare less than 30-day readmissions is where they were losing the most money. But once they ran a report for patients with pulmonary disease and cardiovascular disease, they pulled Medicare, Medicaid, and self-pay and uninsured patients. And with the Medicare patients' heart failure, they were losing around $900 per admission. But for the self-pay patients, they were losing and writing off right at $9,000 a patient.
10 times as much.
10 times as much.
So, I mean, just your initial thought would not be to give remote patient monitoring to a self-pay person, but actually, if they have chronic conditions, it does make sense.
Absolutely. And also, if patients are on Obamacare, those deductibles that you have to meet if you have a hospitalization or an ED visit are so high that patients that even have insurance are not going to be able to pay in a timely manner those deductibles, thus creating the payment process similar to self-pay patients.
So even if they did chronic care management post-hospitalization, they could reduce readmissions for self-pay, and that would have a higher return on investment.
That is correct.
Because they're reducing their losses significantly.
That's correct.
So really, basically, probably saving one readmission would probably pay for that program.
Absolutely.
Depending on their population, of course. But okay.
So it's really helping the organization or the organization really looking at their financials and identifying where they're losing the most money. Or it could be an organization that they're not worried from a financial perspective. However, if they're going to be hit financially because their patient satisfaction scores are low.
Right. Okay.
And if this is a way for that organization to reach out into patients' homes and communities to help keep them safe, will that drive patient satisfaction scores up?
Well, so yeah, because you're providing, it probably feels like concierge care by having someone proactively contact them, and a pleasant person just addressing them in their own home, if they're a pleasant person,
Right.
would be kind of a nice kind of added benefit to them, and that's where you think satisfaction scores would go up. Okay.
Absolutely, and that's been shown in the literature as well.
Okay, so there's research on that.
Yes,
that. Okay.
there is long-standing research on that, actually.
Okay, wait. You're saying there's long-standing research that shows higher patient satisfaction after receiving remote patient monitoring or chronic care management?
Remote patient monitoring.
Remote patient monitoring. Okay.
Yes, I have not seen any published outcomes for chronic care management on patient satisfaction.
For RPM.
Monitoring, yes, absolutely.
Excellent. Okay. Did we cover the biggest challenges and mistakes that you can think of?
No, the biggest challenge for remote patient monitoring is lack of Medicare reimbursement. And so a message to send out to everyone is become involved locally, on your state level, at the national level. There are several bills that are being reviewed and submitted into Congress, and we need to review those, stay on top of the pending legislation, speak to your representatives and senators to try to push these things through, become involved at a state level. There are lots of states that have pulled together telehealth to strategic planning and have made some headway in parity laws in states. In North Carolina, we now have a North Carolina Telehealth Task Force that's looking at developing a strategic plan for the state of North Carolina to advance the adoption of telehealth, remote patient monitoring, telemental health, et cetera, as well as to hopefully to change some of the laws so that there's parity for telehealth.
Perfect. Great.
I think that's it. After you do, look at it, if there's things that are missing, or if you want to do a re-interview or whatever to kind of put it.
Let's do the exit just to say goodbye.
Okay, sure.
Well, Bonnie, thank you for giving us your expertise and experience on this, and helping us talk through a lot of the little issues involved. And I'm sure we'll have you back for more. But thank you for being here with us.
Oh, it was my pleasure. Thank you so much, Jay.
Bye-bye.
Bye.